Thank you for joining us today. We are pleased to have participants throughout the U.S., including Colorado, Missouri, and New York, and from all around the world, Argentina, Australia, Canada, and Uruguay, just to name a few. Welcome. I'd like to introduce our presenter, Dr. Nelson Marquina. Dr. Marquina's expertise is built on a foundation of sciences: biophysics, engineering, statistics, neurology, physiology, and biochemistry. He is the Chief Technology Officer of Laser Biotech International, where he is focused on maximizing the potential of laser therapy in pain relief and tissue healing. He has gained international recognition for his knowledge and his ability to integrate different sciences, technologies, and perspectives. Let us begin. Dr. Nelson Marquina.
Thank you for the introduction, and I assume everybody can hear any comments. You have a chat window, and you should be able to give us a message if you can't see the slide or you're having difficulty with the sound. Okay, anyway. Yeah, all right. Looks like everything's okay. Yeah, again, welcome. I noticed there's some doctors coming from different places. Australia, well, that's midnight there. That was 14 hours difference. It's 2 in the morning. Anyway, we're going to talk about therapeutic lasers, focusing on the temporomandibular dysfunction today. All right, we're going to be covering today is a super brief review of therapeutic lasers. So we'll kind of have a plain level feel for everybody. Then we're going to introduce the concept of craniofacial pain. So we have kind of the landscape where the TMJ pain will fall in. Before getting into the TMJ in particular for pain, and we have to look at the actions and innervations, just a brief review of that actually. And after that, we're going to discuss about why is laser therapy suitable for treating these temporomandibular dysfunctions or these TMDs. And then we will end up with recommended resources. Hopefully people will want to proceed with further research on that. So let's start with a super brief review of therapeutic lasers. Well, photon is just an electromagnetic wave, and one parameter we're going to be using is the wavelength, lambda. So that would be nanometers. And what happens with the nanometers, that defines the electromagnetic spectrum. So in our case, of course, we're living in the infrared domain for laser therapy. And that's, as you can see, the visible from about 400 to about 700. And so the laser we're going to be talking about are more beyond the red, so the infrared, the 800s, 900s, 1000s, and so on. Okay. Now, in terms of wavelengths and absorption, there's a particular curve that I want to mention here briefly, showing hemoglobin on one side for blood and water on the other side. And notice the absorption depends on the wavelength. So the one wavelength is not suitable for everything. So we have to kind of focus on that. I'm going to be focusing on some of the very popular wavelengths at this point. The 650, which is red, of course, 810, 910, 980. I'm not going to focus on all of them because this is focusing on therapy, so tissue healing. So I'm going to be looking at the biostimulation in particular. So that will be the 650, 810, 910, and the 1064. The 980, as you can see, hardly absorbed by water. So that's a nice soft tissue surgical wavelength. But I'm not going to be focused on 980. I'm going to be focusing on the other ones. Of course, the purpose is to put the laser inside the tissue without damaging the surface. So that's not a surgical laser. We want just the opposite. We want to penetrate tissues without any damage to the skin or the underlying layers. So here it shows an infrared beam going through my hand, and of course I'm using an infrared photograph, so I can show that what infrared camera, what it does is converts infrared into white light, so we humans can see it. So we're going to be covering, well, we're shifting to a different area. Let me see if any questions at this point. There's some question coming. Will the laser penetrate bone to reach the nerves? So that's the first question we're getting at. from before that came in the email. Let me just address that real quick. Let's see some. Again, you can use the chat room, the chat window, if you have some questions or comments. The telephone is all muted, so there's no talking about that. Okay. Anyway, the laser penetrate bone without any problem, and we can reach the deeper tissues, including the nerves. Let's move on to the craniomandibular section now, orofacial pain. And I should mention that I learned a lot from this doctor, Dr. Brendan Stack. In fact, he was featured in the craniomandibular practice a few years ago. And that's me in his office. Unfortunately, he's already retired, and he's one of the founders of orofacial pain from the clinical side. Fantastic. He was in Washington, D.C. All right, so let's define craniofacial pain in general. This is the protocol from Dr. Stack, so I call it the Stack protocol. And it consists of a number of key points. For again, this is a craniofacial pain general protocol. It's not just TMJ pain, and he's focused on greater auricular, greater occipital, lesser occipital, trigeminal ganglion. I'm going to come back to trigeminal ganglion one more time. You can see that's next to the ear and just above the zygomatic arch. And same thing for the supraorbital and the infraorbital nerves. So that's what Dr. Stack, he has one more. I want to save that for the best for last, because what he's adding also is the caudalis subnucleus of the trigeminal nerve. So that's part of the protocol too. But I'm going to come back to that one because that's extremely important for TMJ pain in particular. So that's more of that later on, extremely important for us. Bioluminex laser in the craniofacial area can be used for pain relief, whether it's acute, chronic, and neuropathic, which is one of my main interests as a researcher and a clinician, is neuropathic pain. And of course, on the condition would be TMD, whether it's periodontal issues, periimplantitis is extremely important for using lasers to save implants, orthodontics, endodontics, and a lot of the post-op. That's where it happens. And at this point, of course, for today, we're going to be focusing on temporomandibular dysfunctions. So here is the classification of orofacial pain. That's come from the Bell's orofacial pain, which is kind of the standard classification of pain in the orofacial area. And let's position where we're talking today. We're focusing on the somatic side, and the temporomandibular joint pain is classified as a deep pain, and they have it under the musculoskeletal pain. We're not talking about visceral, some other ones, okay? So it's a deep pain, musculoskeletal pain, and there's a temporomandibular joint pain following that. The TMJ pain is classified into 4 different areas or sources: the ligamentous pain, retrodiscal pain, the capsular pain, or arthritic pain. So we're going to talk about all those 4 and from the laser therapy perspective. Of course, there are other procedures and interventions done for any of those pains, including dental appliances, injections, what have you. And it's manipulation, whether it's the joint manipulation, cervical spine manipulation, and so on. Okay. Now, I should mention at this point that on the neuropathic side, in future webinars, we're going to be covering the also what's called burning mouth syndrome. Let's see. Let me just check here the chat. All right. Okay. So neuropathic, a future webinar, we're going to talk about a centrally mediated pain, which is the burning pain. And also in much later webinar, we're going to talk about also what's called atypical odontologia or phantom pain. It's a very controversial area within the dentistry community. Some doctors call it NICO, N-I-C-O, and very, very difficult to treat. Notice that all these conditions on the neuropathic pain that we're going to be discussing later on, including burning mouth, they're all sympathetically maintained pain, which makes it extremely difficult to treat. Fortunately for us in lasers, is quite amenable for laser therapy, as we will discuss in future seminars. All right, so let me just summarize the orofacial pain schematics by focusing on the TMJ. Okay, so within the somatic, is within the musculoskeletal, there's TMJ pain, and those are the four sources or four classifications of TMJ pain: the ligamentous pain, condylar, or capsular, retrodiscal, and arthritic pain. And as I mentioned before, the neuropathy will be a future webinar, and this is coming from the well-known Bell's orofacial pains, well-known in dentistry anyway. At this point, we're going to shift to the TMJ actions and innervations. And I'm going to combine the two, okay, the TMJ actions and innervations together with wise laser therapy suitable for treating temporomandibular dysfunctions. So we're going to look at both. As we look at the actions and the intervention, we can see how laser will be applied to that. So let's move on, dive into just a brief review, the TMJ, right? There you see in the upper left, the capsule and the TMJ ligament covering the joint. Right there you also see the stylomandibular ligament, which is a very source of lots of pain actually, especially when it's calcified. This calcification of the ligament basically have this relentless pain, and in some procedures they just resect the stylomandibular ligament because of there's nothing else you can do. On the lower right, you can see again the sphenomandibular ligament, and notice the nerve, the white pipe. Well, let me put the mouse here. That's the mandibular branch of the trigeminal nerve moving down, coming down. That's the lingual here. So, in fact, in the burning mouth syndrome, we aim for the lingual nerve among the ganglion. The ganglion will be up here. So let's move on. TMJ actions. I don't have a video right here, but as you can see, when the mouth is closed, as we move open the mouth, the joint, the condyle, will move anterior and inferior, as you can see here. All right, and that's it. The disc and the capsule is right here. Now you have the muscles of mastication. There's the temporalis, the masseter. You can see a little bit of the deep masseter branch, and this is superficial masseter branch. Again, this is just a brief overview. I kind of remind you of how what it looks like from the inside. You can see now the pterygoids, and there's the condyle right here. You have the the capsule, and the disc is right here. And of course, the zygomatic arch has been resected so we can see the deeper structures. Now you can see the internal view, the pterygoids, the lateral pterygoid right here, and the medial pterygoid right here. So extremely important structures that we're going to be treating with the laser, even though the problem would be on the joint itself. And there's the condyle, the ramus, and so on. Right, that's right. Reminded the Eagle syndrome. That's right. In fact, in dentistry, it's a very important, extremely unfortunate, very prevalent, more than most people associate with that. That relentless pain there, and a lot of the Ehlers Danlos patients have that also a consequence of the Ehlers Danlos have problems also in the TMJ. And fortunately, again, like I said before, lasers are great in dealing with neuropathic issues or nerve pain in general, neurogenic pain in general. We're lucky. The medical community in general have difficult times when it comes to neurogenic pain and neuropathies. And for us, with laser, helps quite a bit and do the tissue remodeling and tissue repair, including nerve. In fact, nerve tissue is so plastic that is the easiest tissue for us to work with from the laser therapy perspective. A lot easier than dealing with ligament and tendons and bone. Muscle will be somewhere in between, as you can see from the plasticity perspective. This is just getting into more the clinical side. These are different doctors that use our lasers. This is Dr. Nakajima in Tokyo, Japan, and that's how he's doing the assessment of the masseter, and he's treating using the small lumix for that. There's Dr. Goth, he's in Pittsburgh, and he's treating the masseter in this case. again, I'm just flying through, getting a feeling for how the laser is being used. Dr. Nakazawa, he's also in Tokyo, Japan. In this point, he's aiming for the medial pterygoid, but he goes externally. And notice in the next one, that's Brendan Stack again, Dr. Stack, who's treating the medial pterygoid internally. The message here is where do you apply the laser is really as long as you're aiming for it. There are different ways of doing it for the same, in this case, the same target muscle. Dr. Stack likes to go intraorally as much as possible. But the message here is as long as the laser reaches, penetrates the tissues and reaches the target tissue, in this case the muscle, it's fine. You can go externally, extraorally, or internally. This is an example of treating the joint capsule itself. Another example, this is, in fact, I'm doing a class here in Tokyo, Japan, somewhere in Japan, I don't remember what city. And notice that the participant, they're all dentists, by the way, in this particular class. That's the Lumix 245 that you see on the table. And I asked the doctor to open and close the mouth slowly. And the reason for that is when you're opening the mouth and closing the mouth, the tissues are under motion, under function, and they absorb the laser much better. In this case, the doctor, he's a dentist, but he was complaining of clicking and having problems in the disc itself, especially the retrodiscal issues. So I was using the laser and activating the disc motion while putting the laser on. So that's one of the principles in there. We have other classes where we get into the actual protocols and the hands-on stuff. This is just a webinar, 45 minutes. There's so much we can cover into the details on how the lasers are used in practice, including protocols. I just wanted to give you sort of the big picture, the landscape, and more importantly, the rationale why laser therapy is applicable to certain conditions, like in this case, TMD, without getting into the details. Now, Dr. Dragaski, for example, in terms of outcomes, he uses what's called joint vibration analysis, and as part of his diagnosis and to monitor progress, he uses our lasers also. In this case, it's not just vibration, even though the name says JVA, is also monitoring movement, the timing of how the joints are moving. Let's focus now on the mighty trigeminal nerve, okay? Again, just to review, you have the ophthalmic nerve, as we all know, sensory maxillary nerve, and the mandibular nerve. I'm going to focus on the mandibular nerve, which is sensory and motor. It carries pain signals from the face all the way, and the nucleus travels, this is the important point I want to point out. The nucleus of 5 travels caudally all the way to the upper cervical. This is going to be important for us from the protocol perspective, and I'll come up as to why this is crucial for us in terms of dealing with TMJ pain. Just to refresh again your memory, there's the three divisions of the trigeminal nerve, and they go through the trigeminal ganglion, of course, into the pons, but notice there's a spinal nucleus. The nucleus extends down caudally down to the upper cervical. So again, I will come back to that one more time. That's as part of the protocol. Now, one more time to look at trigeminal nerves, just to complete the picture. On the posterior side, you have the nerve roots providing the sensory from the scalp all the way down to the cervical spine. And we wanted to focus on where the trigeminal ganglion is located, because that's one of our target tissues to be treated with a laser. Notice the position with the ear. I mean, I'm not showing the zygomatic arch in this case, but notice the position with the ear. Well, it's not quite accurate. It's a lot closer to the ear than it shows on this picture. Let me show you another one. Here is the trigeminal ganglion. The zygomatic arch has been resected in this case, so we can see the internal one. You can see here the mandibular branch moving down vertically, okay? There's the maxillary branch, and this is the ophthalmic branch, as you can notice there. But let's focus on the trigeminal ganglion for a moment now. And why the trigeminal ganglion and the V3 mandibular, because branches of the mandibular will innervate, provide the sensory to the TMJ. Of course, we know the mandibular branch is the one that provides the motor to muscles of mastication, and muscles of mastication affect the joint. That's why moving the joint. So that's the reason why we're lucky that one nerve, the trigeminal, the mandibular branch, is so nice because it handles both the sensory of our target tissue, but also the motor, the muscles that affect the joint that we're focusing on today. The innervations, as we mentioned before, they have the three branches, and but the auriculotemporal branch, as a branch of mandibular, innervates the TMJ. So that's what I want to focus on now. Okay, like I said before, the mandibular also must provides motor to the muscles of mastication. But here's the key: auriculotemporal, being a branch of mandibular, and mandibular also providing motor to mastication, that's our main target. So we have the trigeminal ganglion and the mandibular branch as targets so far. Okay, let's move on. Just another view of that. There you have the mandibular branch coming down vertically. The ganglion is over here. The zygomatic arch would be right here. And notice here's the TMJ, and look at this nerve right here. This nerve that I'm pointing out, that is the auriculotemporal nerve. So this is going to be our target. We're going to treat the auriculotemporal nerve, the ganglion, and also the mandibular nerve, because that will provide the motor to the muscles. This is the different doctors doing applying this protocol. Here is the Dr. Grusenmeyer. He's from Cherry Hill, New Jersey, treating the trigeminal ganglion on a particular patient. Notice he's a lot closer to the ear, like I mentioned before. The graphic was not quite accurate. This is more accurate there. And the way to find this, just up superior to the zygomatic arch and right next to the ear. Let's see. This is a patient. In fact, we just saw this patient yesterday, treating the trigeminal ganglion, and we will discuss this particular case, a case study from Dr. Trigaskis, for the burning mouth syndrome. So it's a neuropathic issue, but we also treat the trigeminal ganglion in this case for this particular patient. In his case, here is treating the mandibular branch. And I noticed that, there's a question here. Okay, yeah, in the previous slide, I used a different handpiece because the trigeminal ganglion is relatively small. So I want to concentrate the light much more. So that's the reason why I used the previous one with a different handpiece. In this case, I'm using a zoom handpiece. And then in this case, the assistant is treating the mandibular branch all the way down from the ganglion all the way down, including the lingual. He focused a lot on the lingual because his problem was a burning tongue issue. He had a burning tongue syndrome. And in fact, I think I have a picture of it. Yeah, there's assistant treating the actual tongue itself. Here's the other handpiece. Because intraorally, we have to go inside the mouth, so this is a lot easier to work with the extension handpiece. And she's treating the actual tongue. His problem was mostly the burning tongue on the right side. Very uncomfortable feeling, having this electrical quality of pain. As you notice, it's a neuropathic pain. Electrical quality, and it gets in the way of his speech. He can't talk well. Eating and drinking, it affects his whole quality of life is terrible at that point. He has gone through a run of the mill in terms of treatments, injections, you name it, pain meds. And as you know, neuropathic pain doesn't respond to NSAIDs. That's one of the hallmarks of neuropathic pain. Anyway, so we will talk about that more. As you can see, I'm excited about neuropathic pain and both neurogenic pain, including amputee pain and centralized pain. That is my main focus with laser excels. At least our lasers excel in doing that. Let's move on. Notice the relationship between the mandibular branch and C2. They converge in the nucleus. And that's as a plus and a minus. So in terms of diagnosis, I'm ruling out that a patient may have a problem on the trapezius, okay? Because if the patient have a problem in the trapezius, the brain, the sensory brain that's over here, may interpret as pain coming from the TMJ, or vice versa. Patient may have a TMJ problem, and the brain may interpret as problem having a quote unquote shoulder pain, right? Up in the trapezius. So we have to kind of, I'm ruling out that we don't have a trapezius problem here through C2 because of this issue of this crosstalk, okay? There's cranial 5 right here before going to the pons and to the thalamus. This being the thalamus, there's a lot of convergence in there. Here is the spinal level. Notice this is the brainstem and moving down. This is the spinal cord right here, okay? Trigeminal ganglion. The signals go down up to the upper cervical before going to the pons, to thalamus, to the sensory cortex. In the caudalis subnucleus, this is going to be an important area for us. Why? The reason is, I wish we could treat the thalamus directly with the laser. It just can't. It's too deep. It's not physically possible. Well, today anyway, with today's lasers, it's extremely difficult to do that, the work on the thalamus. But the caudalis subnucleus is easily reachable with a laser. And fortunately, I don't know why the good Lord made it that way, the creation. She came out and said, well, let's put the signal down so perhaps these humans will have access to this particular area, the spinal cord, which will be the upper cervical, before it goes up to the brain. And that's exactly what I'm proposing, and I've been doing that for a number of years. What's the big deal of the caudalis? The mandibular branch travels through the caudalis subnucleus on the way to the thalamus. And of course, as mentioned before, controls the muscles of mastication and all the pain signals coming from the TMJ. More importantly, well, both are important, but also the CNS sends pain inhibitory signals, but they also travel through the caudalis subnucleus. Isn't that nice? That in the way up to the sensory cortex, go through the upper cervical, but also the pain inhibitory signals coming from the central nervous system also have to come down through the caudalis subnucleus. That's the reason why the caudalis subnucleus can be accessed through the cervical spine, and that would be a key target from the laser therapy. And there's an example here is the protuberance, the atlas, there is a medulla, the lower medulla, that's where the subnucleus will be located, and we have the access point. So we point the laser right between the occiput and the atlas. And that's about 6 to 8 centimeters, depends on the patient habitus, body habitus, or we can go intraorally. And intraorally, some doctors like to go intraorally, and sometimes like to go from the. But you have hair issues and all these issues that you have to deal with. Here you have water issues and through saliva and blood, and they absorb a lot of the laser. So in either case, there are ways of doing that. And that's what we cover in the hands-on seminars that we provide around the country. So how to do it. I have what's called a short TMD treatment, and very simple. That's if you have not enough time, you treat externally the appropriate muscles. In this case, I'm going internally through the posterior side of the capsule, go through the meatus, but you aim at the capsule in this case, of course. And big time, you have to treat the pterygoids, both the internal and the external. Then no question about that. Some of the doctors use very easy measurable effects right away. Pre-radiation, look at the opening size. Post-radiation, one treatment. This is Dr. Nakajima, another dentist from Japan. It's very gratifying to see the outcomes right in front of you in one treatment. I'm going to elaborate on one particular case. The Dr. Lipskis, he's a dentist in Chicago, and I see the list here. Some dentists attending and some also chiropractors attending the webinar. So I believe the chiropractor will be surprised. Even the dentist will be surprised as to what Dr. Lipskis does for diagnosis. It's kind of an interesting one. All right, so this patient comes in, TMD with severe orthodontic issues. I'll show you in a moment what the problems were. Okay, he also has spinal and pelvic distortions and old trauma before, and he's currently today under pediatric care. Well, at that point, sorry, it's a few years back, under pediatric care, tarsal tunnel issues. But this is the patient. This is don't have a date, but this is a few years back. Dr. Edmund Lipskis, St. Charles, Illinois. But this he normally does that. Look at the the occlusion problems, big time, right? He, as a dentist, look at this chiropractors in the audience. He does full view to see the patient. Look at the plumb line. He checks, even though he's a dentist focused on the orificial area, he knows, painfully aware, that what's up here is connected to everything else, of course. So if you have, in fact, he's the one who referred the patient to the podiatrist because he determined that he assessed, I think it's to determine, he's a dentist, right? But he assessed that maybe some issues coming from the feet location and the same thing with the spine. And notice, look at the inclination, the occlusal cant. Anyway, so let's just move on. This is just a webinar. And he does the tracecephalad pictures, trying to measure. He likes to measure the before and after. Am I getting results or not? And he has the proper computers. He's looking at the pre-treatment, is the black lines, and the green treatments, green trays are the post-treatment. But look at this, the pre-phase one, the temporomandibular dysfunction treatment. This is at the beginning. That was the best way the patient could close the mouth. That's it. And he initiated orthodontic treatment in addition to treating the TMD with lasers. Okay, so again, patients come in with multiple things at the same time. Now, what's the chicken, what's the egg here, or what's the dog, what's the tail, is the orthodontic issue that was presenting, causing problems in the TMJ as a joint, or vice versa, or both at the same time, or maybe coming from the cervical spine. It's multifactorial. So it's definitely multifactorial that should be treated by different practitioners at the same time. But Dr. Lipskis, the dentist, is doing the best we can from this perspective. Look at what happens to by October 21. Oh yeah, this is 9 years ago. But look at what happens to this patient. This is pre-treatment, post-treatment, big postural change. He's a dentist affecting posture, all by working on the dentition portion. Other interventions that we can use, of course, as you can imagine, we can use ear acupuncture, manual manipulation, the joint itself, the cervical spine, manipulation of the trigeminal nerve. There are ways of manipulating manually on the nerves themselves, which is what we cover in the actual seminars, how to do that, and how to manipulate the muscles of mastication. You can use E-stem, radio frequency, pulse electromagnetic fields, all that. I'm just giving a sample. And of course, like I mentioned before, should be part of a program, like say using PNF as part of the treatment itself. Here's in fact, this was a dental group too. I was doing a seminar in Connecticut to a group of dentists, and I added the laser auricular therapy. I'm demonstrating how to treat so-called orofacial pains using acupuncture points on the ear. Taking back to the clinic. Just winding down, converge and summarize. So what? Hopefully you have gotten the picture that therapeutic lasers are used for TMJ pain quite successfully for the relief of musculoskeletal origin. I didn't focus on the neuropathic side yet. Okay, that will be a future webinar. Treating the trigeminal ganglion, the TMJ itself and the caudalis subnucleus yield high clinical effects. No question about that. Doesn't take much time. Trigeminal ganglion is fairly superficial. Okay, so is the TMJ, the joint itself. The caudalis subnucleus, like I mentioned before, yeah, maybe a little deeper, depends on the size of the neck, on the upper cervical, but it is treatable. These three areas give you huge effects in the clinical effect. And laser therapy can be used in conjunction with rehab programs, including dental appliances, by the way. So a patient can have an implant, with titanium surfaces or some prosthesis. That's not a problem at all. One email question that came up before is that can the laser, let me just read it here. Can the laser be used with, yeah, okay, dental implants or prosthesis? So yes, the reason is yes, because the prosthesis, whether it's plastic material, silicone, or metal, they don't absorb laser. If they don't absorb laser, nothing's going to happen, no damage at all, okay? In terms of lasers, at least what we have in Laser Biotech, we have different models. This is the 45 watt pulse power, and this is the 100 watt and 250 watt pulse power. In dentistry or the oral-facial pain, very commonly used is the 45. And the reason is because tissues are small. It's not a huge area. So the 45, we call the 45 watt model for the pulse power is sufficient to treat all the oral-facial cavity. The key is to match the size of the tissue that we're treating to the size of the pulse powers and the average powers. So that's the reason why in the oral-facial pain, dentistry in particular, the small one is fine. So let me just focus now on the recommended resources. And let's see a question that was sent before. How long do we apply the laser to treat the trigeminal nucleus? Well, there would be an actual protocol, and that would be covered in the seminars themselves. We have 8-hour seminars, usually on Saturdays. Check out our website, laserbiotech.com, and on the support tells you about the seminar for webinars and that will coming up later. So let's recommend the resources. There's a website, okay, webinars and seminars. If you want to know more about craniofacial pain, definitely check the Academy of Craniofacial Pain, aacp.org. Okay. Also, the Academy of Laser Dentistry. In fact, there's one of the officers attending the webinar from the ALD. That's laserdentistry.org. And in general, for the whole body was the World Association for Laser Therapy. If you're interested in really now become an expert in craniofacial pain, the AACP has a mini residency in 4 sessions. They really go into depth for that. Okay. Another resources, I recommend this laser phototherapy book, written by Lars Hode and Jan Tuner, the 2 researchers from Sweden. In fact, Jan Tuner is a dentist. And Lars Hode, that you see here on the right side, he's a biophysicist. And together, this is the 3rd edition. If you want the book, you better make sure you get the 3rd edition. It has a lot of clinical practice, lots of protocols about laser phototherapy. This is a personal plug. I wrote chapter 10 in this book, The Scientific Basis of Integrative Health, chapter 10 dealing with lasers, of course. But this book, the lead author, Len Wisniewski, he's a professor in Johns Hopkins University Medical School. But this, just recommend that in terms of the integration of lasers with other therapies. This book was recently published about a year ago or so in Japan. This is focused only on Lumix applied to dentistry. So that's kind of a focus. The whole book is on that. All my customers from Japan got involved and published this book. The title is Pain Relief and Healing, Dental Protocol for Laser Treatments. It's in Japanese right now, but I'm working on getting it translated to English. And that's my partner in crime, Dr. Katsuhiro Nakazawa, who is the co-author in the book. Lastly, I'm going to mention again Bell's Orofacial Pains. This is my Bible when it comes to understanding orofacial pain. And this is more focused on temporomandibular dysfunctions. This is like right here, it's a 700-page book only on TMDs. So it's fairly complicated, very, very important joint. TMJ, look at the cover of the picture. It's a lot more than mastication, a lot more than dentition. Affects the whole body. But more of that coming up later on in a different future webinar. And if you, for those of you who are more on the hands-on stuff, there's a book, I recommend this book on manual therapy for cranial nerves. Yes, you can manipulate cranial nerves. Here's the trigeminal being one of the key things that they're focusing on, including the, well, anyway, enough of that. You can check into that. I want to play my thank you to this man, Dr. Andre Meister, who stumbled on photobiostimulation years back. And thanks to him that we have now photobiomodulation in the US. At this point, this is the end. That's our website. Check it out. Let's just see if we have any questions or comments at this point. Okay, hold on for a moment.
Thank you, Dr. Marquina, and thank you, all of you online with us today. We appreciate your commitment to excellence in laser therapy and hope you will join us again soon. Thank you for your questions as well. If we missed some, we will follow up on that. Our next webinar is June the 8th, and the topic is post-op pain relief and tissue healing with therapeutic lasers. We also have a seminar coming up on June 16th at our training center in Richmond. The seminar is Integrating Physiotherapeutics and Laser Therapy. Again, contact us at laserbiotech.com if you're interested in these or any other opportunities you may want to discuss. Thank you again, and have a nice weekend.